Hello, welcome to this second mini session on the Introduction to Cluster Randomized Trials. And in this session, I'm going to provide an overview of the statistical implications of cluster randomization. So we're going to start by thinking about the statistical implications of clustering. We're going to think about the intra-cluster correlation and what we call a degree of freedom correction. And both of these lead to an inflation in our required sample size. We're then going to go on to think about why cluster trials are used in preference to patient randomized trials in some settings. So we'll think about common justifications and then the advantages and disadvantages of randomizing by cluster. And then finally, we'll move on to take a look at how cluster trials are being used in the current literature. And we'll look at the characteristics of a sample of cluster trials published in 2017. And we'll think about what types of interventions they are being used to evaluate. And just a note that in this session, we're going to look at reported justifications, and we will revisit appropriate justifications in session 2 in this course. So starting with the statistical implications of cluster randomization. So in 1978, Cornfield, in what might probably be the first methodological paper on cluster randomization, said that there were two penalties to cluster randomization. The first of these was the variance inflation due to clustering. This is known as the Intra-Cluster Correlation Coefficient, or ICC. And the second was something called a degree of freedom correction, and this might also be known as a small sample correction. Now, the first of these, the variance inflation due to clustering, or the ICC, is probably familiar to many and is the most widely recognized penalty of cluster randomization. The second, that's the degree of freedom correction, or the small sample correction, turns out also to be very consequential, but is less widely appreciated. So for the next few slides, we're going to look at the meaning of these two things in turn. So starting with intra-cluster correlations. So the design and analysis of data from trials assumes independence of observations. Now, observations within clusters will often be correlated, and this correlation is quantified through this statistic known as the Intra-Cluster Correlation Coefficient, or ICC. Now, clustering will be consequential when treatment assignment depends on cluster, as it does in a cluster randomized trial. And the implication of these correlations are that it inflates the sample size or decreases the precision of the estimate of the treatment effect. Now, in other sessions, we'll look at the concept and implications of intra-cluster correlations in more detail. But here it's sufficient to realize that because of this correlation, the required sample size increases and the precision of our estimated treatment effects decrease. The second penalty of cluster randomization is what's known as this degree of freedom correction. And essentially this is about whether a large sample approximation, i.e. z-test, is sufficient or whether a more exact method is required, such as a t-test. Now, it turns out that t-tests are required when there are less than about 40 independent observations. And when a t-test is used, we need to know what degree of freedom to use on this test. Now, in individual randomization, it's standard and simple to work out the appropriate degrees of freedom because this is just n-1, where n is the number of participants in each of the study arms. In cluster randomization, determining what exactly the degree of freedom is not so clear-cut. There are some simple options, such as 2k minus 2, where the k is the number of clusters per arm. In other sessions, we'll look at, in more detail, determining the optimal and appropriate degree of freedom corrections. But essentially, the implications of a typically small number of degrees of freedom are exactly the same as the intra-cluster correlation. They inflate our sample size and decrease the precision of the treatment estimate. So the statistical implications of randomizing by cluster are twofold. Analysis and sample size must not only allow for the clustering, the ICC, but they must also allow for this degree of freedom correction, and this bit is largely underappreciated. Now the implications are twofold, because this has implications at both the design and the analysis. At the design stage, the sample size that's needed to detect the same target effect size becomes larger than that needed under individual randomization. And at the analysis stage, the variance of the treatment effect becomes larger, so the confidence intervals become wider and the precision becomes less. And we might think about what we might term the effective sample size. And this is compared to that had the sample size that had been realized come from an individual randomized design, and it's effectively reduced. And both the ICC and the degree of freedom have a part to play here. So clustering reduces the effective sample size, and there will be a large reduction in the effective sample size if intra-cluster correlations are high, if the cluster sizes are large, or if we have a few clusters. Sometimes there will only be a small reduction in the effective sample size, and this will occur when intra-cluster correlations are low, when cluster sizes are small, and when we've got many clusters. So what does this mean in practice? So in practice, it might mean that a trial might look very large, but if it only contains a handful of clusters, or if the ICC is very high, then its effective sample size might be quite small. So on this graph on the right-hand side, we've got cluster size on our x-axis here, going from 0 to 500. And we've got what we call the precision per cluster. This essentially tells us how precise we can estimate our treatment effect. The scale here is not terribly important, but what we can see is that this precision plateaus as the cluster sizes increase. Now, as this precision plateaus, essentially, in layman terms, it means that the width of the confidence interval will not decrease. So if this was a real cluster trial, any contribution of observations between, say, 50 and 500 is really having an immaterial contribution to our study, because these extra observations do not decrease the width of our confidence interval. Now this example is for a particular and arbitrary ICC, happens to be quite a large ICC, 0.3. But this type of contribution or lack of contribution from very large cluster sizes isn't atypical in cluster trials. So very large trials might look to be very large, but actually they might not really be statistically that large. So remember the rural cancer trial from session 1. This was set in Australia. It had 15,000 participants. Looks quite big. But actually it only included 2 clusters, region A and region B. And if we work out the degrees of freedom, that's 2k minus 2, actually it turns out the degree of freedom here is 0. So a trial that looks very large, but actually with only 2 clusters, the precision that you get from those very large cluster sizes is going to be quite small. Now, cluster randomized trials face added complexities. So they require a larger sample size than patient randomized trials. We've just been through that in some detail. And this is especially the case when the cluster sizes are large or the intra-cluster correlations are high. But they may be also vulnerable to increased risks of biases. And this is particularly so when the intervention is unblinded and when there is post-randomization recruitment. We're going to look in detail at risks of bias in session 2. Other complexities associated with cluster randomized designs, also covered later, include the fact that they might be more complicated to implement in practice, they are more vulnerable to poor sample size estimation, and they might also be more vulnerable to invalidating model-based assumptions. So, given all of those disadvantages, why are cluster randomized trials used in preference to patient randomized trials, we might ask? So despite these added complexities, such as the increase in required sample size, they are commonly used. Now they can often, but not always, simplify the logistics of the trial processes. And this is because everyone in the same cluster is treated in the same way. Access to other interventions might also be limited, and this might increase protocol compliance. Cluster trials might also require a reduction in research infrastructure. This can be particularly the case if it is ethically appropriate not to take individual level consent, and will also materialize if it's appropriate to use routinely collected outcome data, so we can do away with what we might call case report forms. And all of these things might reduce the trial costs. So they have advantages. They also align with a pragmatic trials agenda. So they often have broad eligibility criteria, and this is often facilitated by not having direct participant recruitment. They're often implemented in what we might call the usual care setting. So they're implemented with similar resources and organisational involvement to what would happen in usual care. There's often flexibility in the delivery of the intervention. Flexibility in adherence is anticipated in the usual care setting, and they often report outcomes that are relevant to patients. So given the competing advantages and disadvantages of the cluster trial, when is the cluster trial appropriate? So there are some common reasons for adopting cluster randomized designs, and I've described them here, divided up into those which I'm classifying to be essential, so cluster randomization is necessary, and those where cluster randomization might be desirable, but individual randomization is possible in theory. So it's essential to use cluster randomization if the intervention is delivered at the level of the cluster. So for example, a change to the electronic healthcare record that's delivered to the entire cluster. It's also essential to use cluster randomization if there is an interest in direct and indirect effects of the intervention. So for example, in vaccine trials, where we're interested in the direct benefit of individual participants through their exposure to the vaccine, but also the indirect effects in participants within their neighbourhood who indirectly might also receive benefits from other people being vaccinated. But then sometimes cluster randomization can be desirable, but not necessarily essential. And these justifications are often described as being a concern over a risk of contamination. So here there's a concern that individuals who have been allocated to the control arm might access the intervention, and that cluster randomization might help prevent or mitigate this. And the other reason is logistical reasons. So these reductions in researched infrastructure might be a compelling reason for adopting cluster randomization. Now we're going to revisit design justification in a lot more detail in section 2. So let's go back to our 4 examples and think through what their reported justifications were for adopting cluster randomization. So in the CAP trial, this intervention was a screening intervention. The unit of randomization were primary care practices, and the intervention was delivered directly to the individual. It was a screening invitation. The justification for using cluster randomization was a concern over contamination and an increase in logistical feasibility of running the trial using cluster randomization. The Survivor Link trial, this was the intervention where an e-healthcare record modification was made. The unit of randomization was the pediatric clinic. The unit of delivery was the cluster level because this modification to the e-healthcare record was made to the entire cluster or pediatric clinic. So this was a cluster level intervention. So in this setting, cluster randomization was essential. In the colorectal screen trial, a list of patients at risk were given to the medical practitioners. So this was a professional level intervention. So cluster randomization wasn't necessarily essential, but it was used because of a concern over justification of contamination and logistical benefits. And then finally, our rural cancer trial. Remember, this was a multifaceted intervention targeting both community members and general practitioners. The unit of randomization was the cluster. The unit of delivery of the intervention was therefore both the cluster and professional level. And so the justification for using cluster randomization here was that the intervention was delivered at the level of the cluster, and so therefore cluster randomization was essential. So let's move on then and think about how are cluster randomized trials being used in the current literature. So first thing to note is that cluster randomized trials are an increasingly common study design. So it's estimated that about 40% of pragmatic clinical trials use cluster randomization. And this chart here depicts citations of cluster randomized trials in PubMed. And we can see a steady increase over the past decade or so. And in a snapshot of cluster randomized trials published in 2017, this was a random sample of 100 cluster trials published in PubMed. It was identified that they were evenly split across most geographies. So about a third were conducted in Africa, about 10% in Asia, Europe accounted for about 30%, and North America about 10%. Most of these cluster randomized trials evaluated health promotion type of interventions, but a non-insignificant number also evaluated therapeutic interventions, so drug interventions, pharmacological interventions. About a third of the interventions targeted clusters. About 40% of interventions targeted healthcare professionals, and about 10% of interventions targeted individuals. The unit of randomization, this is what we refer to as clustering, was diverse. It included such things as health facilities, schools, geographical areas, workplaces, families, and so on. But this review also identified that most cluster trials are small. So the average cluster size was just 48, ranging from somewhere between 20 and 220. But perhaps more importantly, the average number of clusters across both arms was just 29. And the range here was much narrower, the interquartile range being just 20 to 44. So 50% of cluster trials include between 20 and 44 clusters. That's pretty small. Now, the reported justifications for using cluster randomized trials in a random sample of 40 cluster trials evaluating individual level interventions. So these are interventions where cluster randomization could, in theory, have been used, were typically things such as a desire to avoid contamination, and this was cited as a justification in 35% of the trials. Practical or logistical reasons were cited in 5% of studies. No justification was given in about a quarter of the studies. So in summary then, there are important statistical implications of clustering, and these arise at both the design and the analysis stage. We might think of these in terms of the statistical concepts of the intra-cluster correlation and the degree of freedom correction. The degree of freedom correction is required when there are less than about 40 clusters. But we've seen that most cluster trials actually include less than 40 clusters. And both of these things together require an inflation on the sample size over that required under individual randomization. So given this inflation in sample size, we might wonder why cluster trials are used. But they have many positive aspects. So they are aligned with a pragmatic trials agenda. They're actually essential when we're evaluating cluster level interventions. They can provide many logistical benefits, and they're often used to avoid contamination that might arise under individual randomization. And we've also seen that cluster randomized trials are increasingly being used. They're used across a range of different settings, And perhaps interestingly, they are used to evaluate both individual and cluster level interventions. And perhaps more importantly, we also saw that they typically include less than about 30 clusters. So these are the references that I have referred to, that we might refer to and think of as methods references. And these are the study references, the cluster randomized trial case studies that I have referred to. And then up next, in the next session, we're going to go through an introduction to the multiple period cluster randomized trial. And here we're going to start to think about longitudinal designs.